So the next speaker is Dr. Ravi.
Yes. Good afternoon, everyone. My topic is clinical outcomes of toric and monofocal intraocular lens implantation on myopia is target refraction. Coming to the background of my study, a number of advances in cataract surgical techniques have happened in the recent times to improve the quality of postoperative visual acuity. However, corneal astigmatism reduces the uncorrected visual acuity after surgery, and which is one of the most important reasons for increased dependence on corrective lenses. Although a number of techniques are available to correct this corneal astigmatism, toric IOL implantation along with LRA are the most commonly employed techniques, and toric IOL implantation has been reported to be more effective when compared to LRA and is the most recommended method for correcting astigmatism in cataract patients. But there is an interesting situation arises when the target refraction is not emmetropia, but it is myopia like -2 diopters. In such situations, usually surgeons do not opt for toric IOLs because the patients should always wear the spectacles for distant vision correction, for driving, walking, etc. So the astigmatism can also be corrected with that spectacles. However, such patients do not always wear these glasses at home, and they can often take it off when taking a shower or reading a book. In such situations, the uncorrected visual acuity becomes more important. With this background, I go to the purpose of my study to compare the clinical outcomes of toric IOL and monofocal IOL implantation in patients when the target refraction is -2 diopters and with corneal astigmatism more than 1.5 diopters. Methods, it's a retrospective study done over a period of 3 years. All the patients, as I have mentioned, with the age-related cataract with corneal astigmatism more than 1.5 diopters and target refraction of -2 diopters have been included. We excluded all the patients with history of any ocular disease affecting the visual acuity, any history of retinal diseases, or an eye with irregular astigmatism like keratoconus or keratectasia. Preoperatively, we have evaluated detailed medical history, slit lamp examination, fundus examination, and distant uncorrected visual acuity and best corrected visual acuity. And implantation of the lens and the choice of the IOL was given to the patient after explaining the cause. All the surgeries were performed by a single surgeon under topical anesthesia, and the lenses implanted were of Johnson & Johnson Technics series lens. And postoperatively on day 1, first week, first month, and second month, we measured the distant and near uncorrected and best corrected visual acuity, autorefraction, keratometry, and slit lamp examinations. And in toric IOL group, pupils were dilated and see the any rotation 2 months postoperatively. Coming to the results, 40 patients in each group were included. As expected, the uncorrected visual acuity at a distance improved in both the groups, but this improvement, as we can see, was statistically more significant in case of toric IOL group when compared to that of the monofocal group. However, in best corrected visual acuity, there was no statistical difference between the two groups. And coming to the uncorrected visual acuity at near, it was statistically more significant in the toric IOL group when compared to monofocal group. When compared to the spherical equivalent and corneal astigmatism, there was no statistical significant difference between the two groups. However, in case of residual keratometric cylinder, that is the corneal cylinder, there was statistically significant, and it was much lower in the toric IOL group. There were no intraoperative or postoperative complications during our study, and no requirement for any extra procedures were required. The same thing expected here. Coming to the review of literature, a number of studies over a period of time have highlighted the importance of astigmatism as a hindrance to the quality of vision postoperatively. And a study by name Singh et al. Has reported uncorrected myopic astigmatism of more than 1 diopter results in a large loss of distant visual acuity without additional improvement in case of near visual acuity, and uncorrected hyperopic astigmatism results in deterioration of both distance and near visual acuity. The current study showed significant differences between the monofocal and toric IOL group, particularly the uncorrected visual acuity in the toric IOL group was significantly better at 2 months postoperatively. Uncorrected visual acuity can be quite important considering that times without spectacle usage for patients at home may be long. And myopia prevalence at the same time is increasing worldwide considering educational activities, continuous urbanization, and westernization. It is estimated that the number of patients with myopia seeking cataract surgery will increase in the future. And the consultation on toric IOL with myopic target refraction is likely to increase in such patients. So based on the results of our study, we recommend toric IOL implantation in such patients to offer better quality of life after cataract surgery. The limitations of our study included retrospective study design, short duration of follow-up like 2 months, and we did not measure the subjective satisfaction after surgery in both groups. Coming to the conclusions, when myopic refraction such as -2 diopter was the target power with corneal astigmatism, toric IOL implantation led to excellent improvement in both near and distant visual uncorrected visual acuity. Implantation of toric IOL was superior to monofocal IOL group in terms of uncorrected visual acuity in both near and distance. This may be helpful when ophthalmologists consult sick patients, and this could be an evidence in clinical practice to more actively recommend toric IOL when performing cataract surgery in patients with myopia. These are my references. Thank you.
So, I just wanted to ask why, like today, nowadays, cataract is called a refractive surgery. Why you have taken myopia as a target refraction?
So patients who are having high myopia, where the overcorrection or more of overcorrection leading to hypermetropic correction may lead to the more problematic for the patient. Such patients will vote for myopic as target refractions.
No, but in myopia also we can keep it as a target emetropia, and other eye we can do monovision kind of a thing.
So we have taken only one eye in this study, sir. We couldn't take the other eye.
Okay, thank you.